Before we commence, I'd like to acknowledge the tragic events that have recently occurred overseas. The Montefiore community is deeply saddened and know that many residents, families and staff have loved ones affected by the human suffering and loss. Our hearts and thoughts are with them and the broader community. I would like to show my respect and acknowledge the traditional custodians of the land of elders past and present on which this meeting takes place. I'd like to thank you for joining us for our last Montefiore Spotlight event for this year. The Spotlight series allows us to discuss perspectives on ageing and address the issues that affect older members of the community and their loved ones. Tonight's topic is to medicate or not to medicate, and we will be discussing medication management from the perspective of the ageing experience and have a panel of experts joining us this evening. First, I welcome Professor Peter Gonski, a senior staff specialist geriatrician with more than 30 years experience as an aged care physician working in the community and hospitals. He's the Director of South Care Sutherland Hospital and Community Services, Clinical Stream Director for Aged Care and Rehabilitation in South Eastern Sydney Local Health District, and is also a conjoint professor in the Faculty of Medicine at the University of New South Wales, Sydney, and has multiple broad associations and an integral relationship with the New South Wales Division of the Australian and New Zealand Society for Geriatric Medicine. Peter has been a Montefiore board member since 2008 and also sits on several of our committees such as the Montefiore's Quality, Safety and Risk Committee and Clinical Advisory Committee. Welcome, Professor Peter Gonski. Next, I introduce Francesca Gould-Morgan, Montefiore's Senior Dementia Consultant. Fran is a registered nurse with over 15 years of experience in the areas of dementia care, as well as acute and aged care nursing and research. Having worked in Dementia Support Australia, Fran is passionate about supporting residents living with dementia, as well as staff education. She has participated in clinical research on reducing the use of antipsychotic medication and has worked with teams that have won national awards for wellbeing models. Fran is passionate about developing relationships that deliver excellence and promote choice in aged care. Welcome, Fran. I also welcome Natasha Schoen, nurse practitioner at Montefiore. Natasha has been a registered nurse for 14 years and has extensive experience working in emergency departments and tertiary referral hospitals in Sydney. As a nurse practitioner, she has skills and expertise to promote acute care nurse practitioner services for aged care residents. She's a firm advocate for holistic care, and her nursing vocation places consumers at the centre of her approach. Welcome, Natasha. This evening, we will commence with a presentation from Professor Peter Gonski. We welcome your questions and ask that you please enter those in the chat tab at the bottom of your screen. We will try to address all of these after the discussion and presentation this evening. However, if there's any questions, we can certainly answer them offline as well. I'll now hand over to Peter Gonski. Thank you.
Thanks, Sabrina. I'll just get the presentation up. All right. As a geriatrician and aged care specialist, medication is very, very important, because medication can help people, they can make people worse, and we have to detect which one of those it is so that people should continue on the right medication. So I'm going to talk about the good, the bad, and the ugly of medications. The most important thing of any medical problem is to do a full assessment, and I will resort to talking about this when I have some questions later. Assessment is the prime concern, because if you've got the right assessment and the right diagnosis, then you can go down the right management plan. If you don't, then you really go down the wrong pathway, and that really is a struggle for the patient. So management usually is pharmacological from our point of view, but there's a lot of non-pharmacological treatments that should be used and are very effective, and we will be talking a little about this later in the questions. Now, when you think about what medications you take, it's not just what you've been prescribed by your doctor, your local doctor, or your specialist, but it's every single medication that goes into your body. And it's not just what goes into your mouth. It can be any medication that go into a lot of other orifices or on the skin or anywhere. So there are tablets, there are capsules, there are patches, there are eye drops, there are nasal sprays, there are suppositories going up the rectum, and there are injections. And all of them go somewhere in the body. And it's interesting, and people may not know this, that if you put an eye drop in your eye, it doesn't just stay in the eye. It actually gets into the bloodstream and can cause side effects for the whole body. So it's really important to, when you are determining what medication you're on and what the doctors and everyone else who are looking after you know what medication you're on, you have to take into account all the types of medications, but also those that are prescribed, those that you buy over the counter without a prescription, and those that you're given by your friend, your neighbor, your partner, or whoever it is. It's amazing what people take, and all of them are important because they're all going into your body somewhere. Now, from my point of view, medication are very, very important, and everyone is a winner. The doctor hands out a script and expects some benefit for the patient. They're a winner. The pharmacist is reimbursed for their medication, so they're the winner. And the patient takes the medication and hopefully gets better. But sometimes the patient doesn't take the medication and they just say that they take the medication and they still get better. That's the placebo effect. But whatever it is, usually it is a winner. We also find from a geriatrician point of view, when we review medications, is that if we start people on medication, they often get better. But sometimes they get worse. And when we stop that medication, they actually feel better. So we don't lose out. They are going to feel better sometime. So I want to start with a very short case study, possibly a younger person, particularly for the patients I look after. But it really shows us how people basically end up on a lot of medication. This is a 65-year-old who was on no medication. He went to emergency department with chest pain, and they found that he had a heart attack. He was also overweight. He didn't know he had diabetes, but they found he had diabetes, and he didn't know he had high blood pressure, but they found that he had high blood pressure. And they fixed him by putting a stent in his heart, in one of the arteries to the heart. And he was discharged on metformin and sinagliptin for his diabetes, atorvastatin, which is a cholesterol-lowering agent, aspirin and clopidogrel, which thinned the blood so his stent didn't get blocked, perindopril for his blood pressure, and metoprolol to slow the heart so the heart would work stronger. So he came in on no medications, and now he is on 7 medications. And 6 of those medications are probably for life, because you can probably stop the clopidogrel probably after 6 months or maybe 2 years, depending on the type of stent that was inserted. And that person is probably on those 6 medications. And that's just for his heart problem, his diabetes, and his high blood pressure, and his cholesterol. And now, all these medications have actually been shown, sorry.
That's okay.
All these medications have actually been shown to help. And this is a very good graph showing that these drugs actually decrease mortality, and they actually decrease morbidity, meaning they actually make people better. So this is a graph showing that there's a decreased death rate from the medication, there's decreased death rate from heart attacks, there's decreased death rate from stroke, and there's decreased death rate from myocardial infarction, all of which are just related to the blood pressure tablets that they took. And yet they took 6 medications, and all of these decreased the death rate. So medication are good. And what types of medications are good? Antibiotics, but only for bacterial infections. Antiviral medication, we saw the benefit in COVID and for shingles. All of these medications have proved very, very beneficial. But if you use antivirals for bacterial infections, they don't work. Chemotherapy, particularly breast cancer therapy and melanoma therapy, it's just amazing the improvement that we've seen with chemotherapy over the years. The death rate from cancer was so significant previously, and now is so much better. Antihypertensives, as seen in the previous slide, have actually reduced death and stroke and heart attacks. Statins, reducing cholesterol, that's what they're for. They're the highest used medications across the world. They have proven benefit in heart attacks and strokes reduction. These drugs that thin the blood are particularly useful in people who have abnormal heart rates, in atrial fibrillation we call it, where the heart, top of the heart, is not beating properly. These drugs have been absolutely, overwhelmingly reduce stroke risk and are really, really important. Aspirin itself is very, very good for reducing heart attacks and stroke. I must say, though, that people are taking aspirin to prevent heart attacks and stroke. There's not a lot of evidence to show that if you haven't had a heart attack or stroke, that aspirin actually helps. Diabetic medication has absolutely improved mortality and all the complications of diabetes. So medication are really, really good. And what about more recently, what we call immunotherapy, antibodies directed to medication? And these are coming more and more common. So denosumab, otherwise known as Prolia, has revolutionized the decrease in fractures or broken bones by treating osteoporosis. And I won't go through all these in detail, but I can tell you the treatment of melanoma has been revolutionized by this immunotherapy. But all of these have shown their benefit. Now, I will mention the bottom one, and there are other immunotherapy, but within probably 18 months, these will be available in Australia. They're not easy to give. They're given intravenously. They're given every second week. They're only for Alzheimer's disease, and they do have significant side effects. But we will be offering these to people with pure Alzheimer's disease dementia in 18 months' time. Now, what about the bad of medications? And I think that people really mix up the difference between allergies, side effects, and interactions. So if you have an allergy to something, you suddenly break out in a skin reaction or something like that, that is called an allergy. Or you can't breathe after taking a medication, that's an allergy. Interestingly, and it really is interesting, that many years ago, people took penicillin and they said that they were told they were allergic to it, and they haven't subsequently taken penicillin for maybe 40 or 50 years. But it has been proven that the problem with the penicillin then, 40, 50 years ago, was what was with it. And in fact, a lot of those people who are penicillin allergic are no longer penicillin allergic because they were never penicillin allergic. They were allergic to the compound which had penicillin in it. And why do I bring this up? Because penicillin is still the most important antibiotic that we have. And if people are allergic to it, it really minimizes the types of antibiotics they can take. So it's really important that we absolutely say, did this person get an allergy to a certain medication or did they not? Side effects are incredibly different. Side effects are a reaction to the drug itself. And that could be diarrhea. It could be vomiting. It could be a skin rash. But these are side effects. They're not allergies. And it's really important because lowering the dose or changing the medication to a different one might be all you have to do. And interactions, when people are on a lot of medication, the drugs interact. They have different ways of being broken down. And they might have basically a situation where one drug is broken down in a certain pathway and another drug is broken down in another pathway, and they might compete for that pathway. And therefore, there might be an increase or decrease of dose in the blood. And it's really important that we understand these. Now, the bad also is the cost. I mean, for PBS, that is the ones on the government scheme, they're actually pretty reasonable. And I might just say that generic drugs, that is a whole lot of names of the actual drug, are much cheaper than other drugs which are the same ingredients but come with a different name. Now, people always say, I need to have this particular one. That might be the case, but generally a generic one is equal to any other one. So if you want to save on money, then you may as well ask for the generic. Some pharmacists will not give you the generic because they'll make more money out of you. Are any drugs exempt from the bad of allergies, side effects, interactions, cost? The answer is absolutely no. There is no drug that doesn't have any problem. The benefit, though, is much more often than the bad, and that's why we are able to give people medication. And I'll just, as in the cartoon shows, that there are some people who feel so much better when they actually stop their medication, and I did allude to that when I first started this talk. Now, I just want to talk about polypharmacy because it's particularly common in the elderly, and it is defined as more than 5 different medications. Now, that may be ones that are prescribed or ones that are bought over the counter or ones that you use from someone else, but it's 5 different medications. And as you can see, in the over 70-year-old population, a third are on more than 5 different medications, and half of over 85-year-olds are in this polypharmacy group. And the average number of medication that an over 70-year-old takes if they enter into a hospital is 4.5, and when they go home, it's 5.5, and often it's very different medication. As I said, you have to include prescriptions and over-the-counter and every other medication you take. And polypharmacy can be good, as in, if all those drugs you're taking are doing you a world of good, well, then it's good. And you might need every one of them. But they're also bad because they interact and there's more chance of side effects. Now, I just want to say that body organs compete for medication effect. And some body organs don't like other body organs. And these are really, really important. So we have medication that improve bladder control, and they're terrible for the brain. They make the people confused. Or people who are on dementia drugs can make the bladder worse. They can become more incontinent. So the brain and the bladder actually don't like each other very much. Sometimes the brain and the brain don't like each other very much. If you've got Parkinson's disease and you go on Parkinson's medication, sometimes it may cause side effects which lead to some mental health symptoms, such as delusions or hallucinations. The heart and the kidney hate each other. If we want to dry out the heart so people don't get fluid, we sometimes dry out the kidney at the same time, and the kidney doesn't like that. Or if we pour in fluid, because we want to overcome that problem and improve the kidney, the heart goes into fluid retention. So a lot of these drugs do not like each other. A lot of these body organs don't like each other. And as I mentioned previously, and people would be surprised at this, that if you take some, and I'm not saying all, glaucoma drugs, it can slow the heart. And we have had people who've actually collapsed from a slow heart because they take glaucoma medication. So all drugs, all organs have to be taken into consideration. Now, there are increased risk of side effects and interactions if you take more medications, particularly if you have polypharmacy. The older you are, because if the older you are, there's more likely you're going to have kidney disease and liver disease. And there's only really 2 big ways that we get rid of drugs that go into our system, and they are via the kidney and via the liver. And all those drugs compete with each other, and that's why we get those interactions. And the smaller you are, the more likely you are to get interactions and side effects from medications. Now, I just want to have a word about antibiotics. It's really important that we don't use them for non-bacterial infections. So if you've got what we call a strep sore throat, then it's very reasonable. If you've got a viral sore throat, you shouldn't use it, because what happens is the more people use it when they shouldn't be using it, the more likely that those antibiotics are going to be resistant next time they need an antibiotic. And as I said, penicillin is really the best drug for everybody to make sure that we don't get resistance, because there will be a time where you would really benefit from having penicillin. It's really important that people don't use these medications a lot, that we don't give them just because we think someone's got a bit of a fever and they should use it. And the worst place where the problem is with antibiotics is hospitalization, because we throw around antibiotics all the time, and there's a good reason, because people come in very sick and we have to throw in their antibiotics as quickly as possible so they do well. And this is from the emergency department. They throw a lot of medication around, and it's a reasonable thing to do because we don't want people to get sicker while they're sitting in emergency. And the problem is that the drugs they use, they get resistant. And sometimes we can't use those drugs for pretty straightforward infections. So it's really important that we will protect antibiotics as much as possible. Now I want to talk about compliance, particularly in older people. At least 25% of older people are admitted to hospital with a medication-related problem. This could be a side effect from a medication. It could be an interaction with another medication. It could be because they're not taking enough medication and they're not any better, for example, in a heart failure. Or there could be that they're on too much medication and they're having side effects and they're reacting to it. So there's lots of reasons, but it's an astonishing number that 25% are in some way medication related. And that's why being on medication is just so important to our health. So compliance is critical. We need to make sure we're on the right drug, we're on the right dose, we take it at the right time. And this is particularly important in Parkinson's disease, because people with Parkinson's need to take it when they get very stiff and slow down, and they need to take less when they're not quite as stiff and slow down. But it could be related also, the timing is really important with antibiotics, whether they should be taken with food or without food. And also with blood pressure tablets, we find a lot of people should be taking them at night, but nearly everyone takes them during the day. And they should be taking them at night because their blood pressures first thing in the morning can be very, very high. And don't forget the reaction with alcohol, because alcohol does relate to a lot of drugs, and it's particularly due to the breakdown of these drugs. So it's really, really important to improve compliance is good communication between all health workers. That's all doctors, GPs, all the specialists, but particularly the pharmacists, because they are the ones who basically give people the medication. And it's important that you have one pharmacist, not 3 pharmacies that are passing out medication to you. And also, please try not to take other people's medication, because the ones that are prescribed for you are best for you, not someone else's. The benefits of medication, aids, are really, really important. And I've got here a Webster pack or a blister pack, and it's basically gives you the whole week's medication. So there's all the days across down the side and all the times you're taking the medication at the top. And it'll tell you whether they're having morning, lunchtime, afternoon, or nighttime medication. And the really good thing about that is, firstly, it gives people don't have to deal out their own medication from lots of boxes and bottles. Secondly, we actually know they've taken them because they're we know that they've opened them up anyway, and we know whether they're taking them at the right time and right place. Thirdly, they've all got a list on them that you can take to your pharmacist or GP or specialist, telling them exactly what you're taking. It's really important. Not all medication can be put in a pack. Obviously, patches can't, and there are actually some oral medication that can't be put in a pack as well. So it's really important that we review medications. And the main thing is the course that you're getting, should be it short or forever? That's a real big question. So antibiotics and sedatives possibly should be only a short course, but we see people taking sedatives years after an event of anxiety. Do they need it? Has the dose been reviewed? As you get older, the kidneys and the liver don't work as much, or even if you're younger, your kidneys and liver may not work as well. And The dose may need to be titrated down or up. Where are the medications? Are they in a pack? Are they in a box? Are they in a drawer somewhere? Are they all over the house? I've seen some patients where the medications are everywhere. Is there a list? Is there some type of blister pack or Webster pack that we can actually have a look at? And it's really important that a GP and or a specialist, but particularly the pharmacist, helps you in reviewing your medication. I might just say at this point, pharmacists are exceptional at looking at all your medication, but doctors sometimes will prescribe medication which pharmacists say they do have an interaction, or you shouldn't be doing this with this. But occasionally we will do that because we know the benefits of that medication for someone in that particular situation. So deprescribing is basically looking at the medication and hopefully reducing the number of medication you're taking. And that's what geriatricians do all the time. But it can be good and it can be bad. If you really require those medication, it's a good thing to review it and take them. If they're interacting or you don't need them anymore, you shouldn't be buying them and you shouldn't be taking them. So what's the ugly of the good, the bad, the ugly of medication? I'm coming to an end now. It's all about understanding what you are on, the indications of the medication, the doses you're meant to be taking, and how often are you meant to be taking it. Go low, go slow for long-term medication. So we start at very low doses because some people respond very well. And if they have side effects, they're going to be much less side effects than if we start at very high doses. And we just slowly increase the medication dose and the frequency. Liaise with your GP, specialists and pharmacists to review your medication. And just remember, it's your body, it's your balance, and it's your seesaw. So it's all about the benefits and the side effects. If the benefits are more than the side effects, you should be taking those medications. If the side effects are more than the benefits, then probably something else should be used. Thank you, everybody, for listening. I'll just go to the cartoon, and that is, right now I take a blue pill, a purple pill, an orange pill, a white pill, and a yellow pill. I need you to prescribe a green pill to complete my collection. Thank you all.
Thank you, Peter. That was a wonderful presentation. So many informative points, and certainly your comments about understanding how medications work and how our body responds to them was really fascinating. I do have some questions for the panel members, and we'll come back to you, Peter, if there's any additional questions from the audience as well. So Natasha, as a nurse practitioner at Montefiore, what are some of your common observations around the use of medications, particularly with those people that have been living at home and they're coming into residential care?
Thanks, Sabrina. I think Peter touched on the first one that I wanted to mention, which is their medication list is not always the true picture of what the individual is actually taking. So part of my role at Montefiore is to actually sit with that resident and work out what they are taking on that list and what they're sometimes taking on that list and what else they've got in the cupboard, because there's always another medication that's in the cupboard that you will not find on that list. So that's just touching more on Peter's point there. The second one would be that the medications that they take on a daily basis once upon a time, such as medications to treat reflux, that now no longer needs to be taken maybe on a regular basis. So maybe just when required, maybe sometimes after a heavy meal. So I think that's just another point that's really important to, what was taken once upon a time, 20 years later may not need to be taken anymore. And in regards to just looking at the transition of new residents into the aged care facility, it's really important for a smooth transition to actually be transparent with that loved one and also communicate early so that they feel like they've still got a voice and they've still got some decision-making abilities. Thank you.
Thanks, Natasha. Peter, I do have a question in the chat, whether or not there's a test for an allergy, if you do have an allergy to penicillin.
If you are told that you've had an allergy, you need to get the full history if possible. But if it goes back many years, there's actually ways of testing you. And how we do this is we actually, and there are protocols, I wouldn't just go and do it, but there are protocols where you can take small amounts of oral penicillin and under surveillance, so someone watching you, they can actually see whether you have a reaction. But because it's a very small dose and because it's oral, people don't usually have a significant reaction. So if you are someone who has an infection and the doctor really, really wants to put you on penicillin, and really you want to know for the future, there are ways of testing this.
Fantastic, thank you. In your presentation, you mentioned the importance of taking the right medications, the right dose, and certainly at the right time. So what type of advice would you give to someone who maybe has concerns about their loved one and how they're managing their medications at home?
Yeah, look, I think the first thing is that this is a very concerning issue. And I mentioned that, you know, a lot of people go into hospital because of medication issues, and they don't realize that they go in with symptoms and the doctors go through all the medications, because that's what we do. And we realize that these medications are causing the problem. And I do the same. I mean, I treat, for example, let's say dementia with some medication, and one of the side effects is severe nausea. It's very rare, but so someone might end up in emergency with severe nausea. And if you just look down the patient list and you see this, you'd want to probably stop it, particularly if they've just started it. So it's a very concerning area. I think the most important thing is firstly, review the medication and see, are these medications actually needed? And so often I have looked at a whole list and said, well, actually you're on 5 medications, and you know what? 4 of them are really not doing anything for you. Let's get rid of 4. And that'll kind of improve in compliance, because that person is now on 1, not 5. And the last thing I want to say is that we can take medication dosing much easier. So there are medications that are given twice daily, but there may be similar medication that can be given once daily. And how easy is that? And the other thing is that we can improve the way people take them. And I mentioned the packs, the Webster packs, or any of those packs. There are lots of other ones. We use that one most commonly, but there are lots of other ones. And it just improves that compliance. So there's a lot we can do for compliance and to try and improve the way people are taking their medication.
Yeah, absolutely. Thank you. Natasha, Montefiore is very fortunate to have a strong interdisciplinary team approach. We have over 13 different allied health professionals. They include physiotherapists, dementia specialists, occupational therapists, and so many more. But if I was at home, I may not be very familiar about how some of these health professionals can help me, especially perhaps when it comes to pain medication and managing pain. Have you got any insights into how allied health professionals might be able to assist with residents struggling with pain management?
Yeah, so there are many ways that I can work with the allied health team to sort of improve that optimal patient experience at Montefiore. So an example of this would be a resident that has had a fall and they've fractured their wrist. So we would get the physio to come with me and stabilise that fracture by putting on a cast. This would obviously be after we've done an X-ray. Sometimes if we can't get an X-ray that day, it'll be just for pain relief though as well until we get that X-ray. The OT will also assist and give equipment such as a gallows sling. So that's just a sling that we use to elevate the arm to reduce the swelling, which the swelling will reduce the pain. So that's also another pain relief option. Then we also have social workers that are on site, and they provide emotional support as well as further resources for managing their pain long term. The other case study I wanted to talk to you about just quickly is just one of my regular residents that I see, and she actually says that she's living with chronic pain. So she says that the art therapy is probably one of the best ways that she's able to manage her pain, because I'm assuming the benefits are creative mindset, she's socializing with other residents, And also she's completing a project which she either gets to keep or she can give to a loved one. So that's definitely on my bucket list to one day get to one of those art therapy sessions.
Certainly. And for those at home, it's important to know that there are services available. Your GP can help refer to allied health services, but there's so many things that you could also do at home, such as keeping physically active, going for walks, joining group exercise classes perhaps, but certainly that social engagement part, visiting friends, families, spending time with grandchildren at the park, or just enjoying leisure community group activities. They can be so beneficial for your well-being, and we really find that that sort of distraction is a great therapy as well. Fran, over to you. So as a dementia consultant, how do you assess pain and how do you approach pain management change, especially for residents or those that are living with dementia at home?
Thanks, Sabrina. Yeah, I think I'd like to start just by saying pain in general for everybody is individual. So you may have somebody with the same condition or injury or illness, but their pain experience may be very different. And it's important to validate that that is what they're experiencing regardless. In terms of people that can communicate, it might be someone living with dementia, maybe that they can't communicate well or precise, or they can't communicate at all. But the things that we would look for those that can't verbally communicate would be things like facial grimacing, frowning. They may make moaning, groaning noises. You may notice that if there's a particular body part that they start to guard, they don't want anyone to touch it. But also with that, it might be that they're changing their routine. They may be sleeping differently. They may not be sleeping at all. It could be that they're withdrawing from their usual social activities or wanting to stay home more. I think definitely something that I see, and it's quite common in aged care overall, is that pain usually has some part to play when somebody, I guess, is agitated or displaying a responsive behavior that we're thinking that's different, that's concerning, something's happening. And usually pain has a little part in that, if not a big part. So it's very important that we look at that. And in terms of treating or managing pain, it's much like anybody else. You know, we may look at the non-pharmacological strategy, so no medication. That was mentioned before by the physio, the OT, whether it's massage or exercise. But they may also need pain relief. They may need something acutely, so short term, to treat whatever it is happening, or it might be that they need something longer term, regularly to maintain, I guess, that pain relief for them. Yeah.
Thank you. And Peter, if you'd like to add to that, or just in general, we've had a query about if you're taking a regular pain medication, but you're still in pain, you might be tempted to take someone else's recommendation on what works for them. What type of advice can you give to someone that might have uncontrolled pain?
Yeah, I think the most important thing about pain is a very good assessment, and that includes determining how much pain someone has, where it is, how long they've had it for. Is it sort of started in the last week? Has it been there for 10 years? And also you have to take into account, as much as other things, is people's mood. Are they very depressed? Because that increases their feeling of pain. So I think the first thing is to do a really, really good assessment to see what works, what doesn't work, and possibly even go into what medication they're taking and how they're taking it and why it's not working. That's the first thing. Next thing is we really need to have a look at the non-pharmacological treatments. So that's already been mentioned, that there are a lot of things we can do without taking pills. And also then once we are taking treatment, maybe local treatment rather than drugs that go through your whole body. So there is local treatment like a cortisone injection into a knee can really help gout or arthritis, and then you don't need to put tablets in your body, and it has to basically go through everywhere. So that's the next thing. Now, with regard to taking someone else's medication, I mean, it's all about, are you the same type of person? Do you have the same breakdown in your kidneys and your liver? All of those things have to be taken into account. are they taking pain medication for one thing and you're taking pain medication for a completely different one? And I will mention that there's pain that is very local pain, and there's pain that is very common, which is related to our nerve endings. And the treatment is incredibly different. So if your friend or neighbor or whoever it is taking it for local pain, that is, say, arm pain or something, and you're taking it because you've got terrible burning in your feet, the treatment's going to be totally different. So I really think that it's not a good idea to take other people's medication. You can maybe suggest to the GP, look, my friend did well on this medication, can I give it a go? And that prompts a good assessment of pain and what someone should be taking.
Absolutely. Thank you. Natasha, as a nurse practitioner, you often speak to residents about polypharmacy, and Peter mentioned some of polypharmacy in his presentation. What's your approach when you have discussions around how many medications people are on or how many they're taking on a day-to-day basis?
So I think it's always important to look at what, as I've said before, what they are taking. It's important to maybe reduce the medications one at a time, and that could be for a couple of weeks. As Peter's also said, slow and steady is always the best way. And risk to reward. So we're looking at, are they doing better being off those medications, or are they doing better on those medications? And that's really individual. So it's just making sure we have that individualized, holistic approach for them, and not going, oh, well, this worked for someone else, so we're going to do it this way. So, yeah.
Thanks so much. And Peter, you did mention some suggestions and what to do at home. Would you like to add anything else about polypharmacy?
Well, I think it's all about review. And sometimes it doesn't matter who reviews it, as someone who's specialized in that area. So it could be general practitioner, it could be specialist. We do a lot of that. Pharmacists are really, really good. Nurse practitioners. We all have a lot of skill in this, but I just don't want the audience to leave us and think that polypharmacy is all a bad thing. I have stopped people's medication because I didn't think they needed it. And of course, lo and behold, a week later or a few weeks later, they come to me, or they come into hospital, or something goes wrong, and it's all related to that medication that's been stopped. So let's not think that this is a total disaster. All I'm asking for is good assessment, making sure that people are on the right drugs and that they have had a review of maybe stopping medication that were very useful years ago, but not so useful now.
Absolutely. Thank you. And Fran, you're really passionate about behaviour support. Can you tell us about your role in the allied health team and how it relates to the use of medications for people living with dementia?
Yeah, so I guess generally speaking about my role, it is to support people living with dementia to continue to live their life the way they choose, which is also part of the Montefiore experience. Usually when I get somebody referred to me, it's generally because there is some kind of concern that a carer or someone nearby has, that they aren't able to provide the best care for that person anymore, whether the person is more agitated or something has changed. So like what we were talking about with pain, I start with the clinical. I look at the clinical factors first, because it could be pain, it could be an infection, it could be a delirium. And sometimes we can rule out, if it is something in the clinical realm, we may be able to treat that, and then that may change the behavior in itself and may either reduce it or completely get rid of it. But moving on from that, if we've looked at the clinical and it hasn't really changed what's going on for this person, I'd be looking at things like the environment. So is there something in the environment that's not working for this person anymore? Is it too noisy? Is it too cluttered? Is it that they have difficulty finding their way around? And then lastly, and probably one of the bigger things, is looking at someone's social history. So if you're looking at their social history, we're going back in time, and it could be that somebody has had some kind of trauma in their past, and they're now living with dementia and they're reliving this trauma, and they may not be able to differentiate between the past and now. So they think it's happening now and it's very real. And so keeping all of those things together, part of my role would then be to create strategies and support staff, residents, families, and educate them to be able to use those strategies to find a different way. It's up to us to change our behaviours to be able to help somebody living with dementia or cognitive impairment. I will touch on medication though, in terms of, it's quite a big topic at the moment, antipsychotic medication. Best practice generally says that if someone is living with dementia, antipsychotic medication is not usually what they consider best practice. However, they may have a dual diagnosis or a mental health condition or something acute happening at that time where they may require that medication. They may require it for a short period of time. They may need it for 3 months while we're trying to figure out what else is happening. And of course, because we've spoken earlier about it, there are individuals that do need it, and it is suitable for them regardless. So it is a big topic at the moment, and each individual would need to be assessed as they are and their situation and background. And then I guess further from the support and the education, part of my role is also to provide links to the community and to resources. So if the family need to reach out to someone for further support, counselling, my role would be to help them navigate that. But yeah, generally I'm here to make sure that the person living with dementia can live their life the best they can and enjoy it.
Thanks so much, Fran. And Peter, just lastly, in terms of medications that do alter our mood or assist with behaviour, often they are prescribed as last resort. Can you share your insights, because these can definitely help with consumer wellbeing or resident wellbeing, but also in the community, can help with staying in the community longer. Do you have any insights or advice around those class of medications and how they can support our wellbeing?
So firstly, I want to just say that everything Fran said, I absolutely go along with, but the most important thing is assessment. And part of that assessment is what is the behavior and how's it affecting the person and how's it affecting people around them? Because even though someone might have some unusual behavior, it doesn't mean we necessarily have to treat it. The next thing is, and Fran alluded to this, is we need to look at non-pharmacological treatment, particularly changing the environment or the way we interact with people. The next thing is that people who, for example, might have pain, they might cognitively go off or show behaviors which are unusual for them. So we have to give them doing a pain assessment and then give them analgesia. If they're very, very depressed or anxious, antidepressants or anti-anxiety treatment can actually settle them. If their dementia has not been treated, sometimes we can give them dementia drugs and they just improve that little bit where that behavior is not such a problem. So we treat the underlying cause. Then you get to the stage of saying, this person has a behavior, we tried everything, we've done a lot of behavioral therapy, environment, we treated their conditions, but we're still running into significant problems. If people are seeing things that are agitating them or thinking things are happening that are agitating them, then antipsychotics can actually be incredibly useful. Now, I saw a patient today who I put on antipsychotics 3 months ago. He has severe dementia. He lives with his wife. His wife was telling me the terrible time she was having with him due to his thought processes being really abnormal and him getting up to things all the time. And we gave him a little dose of antipsychotic, and in this case, risperidone. And all the family came to me today with big smiles on their faces. Now, they may not need that. He may not need that for a long period of time, but I've continued it because they are overwhelmed by the change in the way that he can be at home and be settled. So it's really important that antipsychotics we have to be concerned about. We try not to use them, but in certain circumstances, they actually do work. And we have to basically follow these patients and make sure they're not getting complications and then try without them. And the last thing I'm going to bring up is cannabis, because we are starting to use medicinal cannabis in a few patients who have basically done very badly on these antipsychotics. Actually, Israel is probably and Canada are the biggest countries that use cannabis. In Israel, there's some great studies on autism and the behavioral disturbances or problems related to autism. They've got some great data, and we're starting to use it in dementia. And we've had a couple of patients who really were very, very hard to manage. They took cannabis and they were just more settled. They were less intrusive. They weren't wandering quite as much. And everyone seemed to be quite happy with the outcome. It doesn't work for everyone. In fact, I'm sure of that, but sometimes it's worth a try.
Thank you so much for those insights. Certainly, we do see some, especially for pain management, it's been used and prescribed in some of the residents that live with us here at Montefiore. So we do have about 9 minutes left, so I'll just go through a couple of extra chat questions that have come through. Now, I'm not entirely sure what type of blood pressure medication this person's referring to, but I'll pose the question to Peter Gonski. So the person's written in to say that they take blood pressure tablets in the morning at breakfast, and the prescription says daily. There's no indication of when during the day. Is that a problem?
Yeah, that's a great question. And why I bring that up is because I have a lot of in-hospital patients as well as outpatients. And we do rounds in the morning and we see, oh, the blood pressure is so high when we see them. Hopefully it's not totally just because they're seeing a doctor. But even when we're not there, it's very high in the morning, and sometimes it just drifts down as the day goes on. Those people should be taking their blood pressure tablets at night rather than in the morning, because if they take it in the morning, what's going to happen is their natural body is actually going to drop their blood pressure, and we give them more blood pressure tablets, and then their blood pressure gets too low during the day. The best way to sort this out, and I do think that sometimes if people have got significant blood pressure problems, if they can have their blood pressure taken first thing in the morning and basically in the evening, and just see what their trend is. And if it's good most of the day, well, that's fine. If it's really high when they wake up, but it's actually low during the day, then they should be swapping their medication, or the GP should be swapping their medication to take it at night. And this is not a small issue, because people often fall over during the day, and it's often related to their blood pressure tablets because the blood pressure is just getting too low. So I'm not saying that everyone should be taking it at night. In fact, most people take it in the morning. But if you can somehow have your blood pressure taken at various times during the day over a week or two, and just see what the trend is and show it to your GP, it might be worthwhile just swapping your blood pressure tablets from morning to night or night to morning or whatever.
Thank you so much. I do have a couple of extra questions in the chat. So the next one is, should a person's diet as well as their level of physical activity be considered when reviewing their medication? Who'd like to answer that one? Peter, would you like to answer that one?
Look, physical activity and diet are so important. In fact, what we've found is that physical activity, mental activity, just socializing and having a good diet and minimizing your alcohol intake and stopping cigarette smoking, that actually solves so many problems. Did you know that 1/3 of people who are put up for a knee or hip operation, if they lose weight, they don't need that operation? 1/3. It's incredible. So all of those things are really, really important. So I think that one should follow a good diet, exercise, and then the medication should be on top of that. So if you're taking medication and what happens is that you suddenly decide, I'm going to do a good diet, I'm going to lose weight, I'm going to do plenty of exercise, you should have that medication reviewed, because you may not need it at all, or you may need a reduced dose.
Thank you so much.
I think as well, oh, sorry, I was just going to say as well, it's really important sometimes with opioids that they can cause constipation. So that diet and exercise really does have a place. And, you know, we're lucky here at Montefiore that we have dietitians that assist with those issues, and they're part of our team that we work really closely with. So very lucky.
Good point. Thank you. And I have two final questions in the chat. So just regarding cannabis and whether or not it can be used to settle agitation. And what about the potential, the consideration for increased falls, and whether CBD only with no THC would be considered?
Okay. Can you just, I didn't actually hear what the first part of the question.
So could cannabis help settle agitation?
Yeah. Okay. So if you go on the website for cannabis, there are 40 diagnoses that you can use cannabis for in Australia. One of them's anxiety, one of them's pain, one of them's insomnia. So you could just about think of anything you've got, and there is a belief possibly that cannabis might be able to help you. I don't really believe that, but pain, pain, anxiety are the two really, really big ones, and they are really beneficial. Now, with regard to THC and CBD, which is the combination, firstly, the first question I ask is, do you drive? If you drive, basically you can't take THC, because these days in New South Wales, if you stop by the police and you have positive THC in your blood, you will get a fine. So I don't give THC to anyone who drives. Anyone who doesn't drive, then I have to decide, is there a combination between THC and CBD or just CBD alone? Now, they're both beneficial. I prefer to give people a bit of a combination. It is true that there's probably less side effects with the CBD alone, but there's probably more benefit for a number of conditions where you can use the combination, for pain particularly. So I think, again, if you're going to take medicinal cannabis, it should be proper medicinal cannabis, not just what you've bought off the street or somewhere. It should be proper medicinal cannabis that you get through a medical situation, and you really need to trial it. You use small doses, you slowly increase it, you look out for side effects, which are actually very minimal. But the main side effects are, you can have falls, but it's pretty rare. You can get nausea and you can get dizziness and you can go off your food, but they're all pretty rare. In chemotherapy-induced vomiting, it actually is very, very beneficial. So, you know, the fact that you get nausea with cannabis, the other side is you can actually get rid of vomiting with cannabis.
Thank you so much. There is one more question, and I might just divert them to the list or the web page that you suggested, Peter, because it's about cannabis use for autism. So I might just refer that person to look up on the websites, but certainly to have a discussion with their GP or their prescriber specialist. So we're nearly out of time. So I'd like to thank everyone for joining us this evening. I hope that the information, the discussion has assisted you. Thank you for your questions and your participation. Particularly thank you to our guests, Professor Peter Gonski, Fran and Natasha. It's been great to have your advice and your insights. We will be sending the recording of this seminar to all of those that registered. We've had some great participation. Over 70 have joined live, so thank you. And we'll also be sending further information for resources that might be able to assist you, like Dementia Australia, or even some of our Montefiore services for help at home, but also residential care. So thank you again, and we hope to see you at our next Spotlight event, which will be in 2024. Thanks, everyone.
Bye.
Thank you.